Good afternoon, everyone. My name is Ellen Hicks, and I am the Director of Care Navigation here at the Parkinson Association of Alabama. And we are so excited to have you all today. And we are beyond thrilled to have Dr. Nicole Bentley here to share her insight and wisdom on the DBS procedure. Before we begin, I wanted to go over a few little housekeeping items. This will be recorded, so you will receive a follow-up email after the webinar with a link to the presentation and also any kind of resources or pertinent information that we feel you may want to have at hand. Also, if you have any questions, for those of you who are not familiar with Zoom or maybe just need a little tune up, there is a chat button at the bottom of your screen. You are welcome to use the chat function to type in a question. There is also a button down there that looks like a little hand. If you want to ask a question, you can raise your hand and we can call on you, or you are welcome to kind of blurt out your question. So I believe that kind of covers us for the housekeeping part, and I am happy to introduce to you all Dr. Nicole Bentley. She is an associate professor and board certified neurosurgeon at UAB and specializes in deep brain stimulation, epilepsy surgery, and functional movement disorders. She attended the Medical College of Georgia and completed her residency and postdoctoral research at the University of Michigan, where she then went on to complete her fellowship in functional neurosurgery at Emory University. She lives in Birmingham and has three beautiful, beautiful babies, or children, not all babies. But without further ado, here is Dr. Bentley. Thank you so much for being here.
Thank you for having me. It's an honor to be able to speak to everyone and to be invited. So I really appreciate the invitation. As mentioned, I'll talk mostly about the surgical process of treatment of Parkinson's disease with deep brain stimulation because that's what I do every day. And I would like for this to be, mostly questions that I can help answer. So the presentation here, it will be pretty brief, and then I'm happy to stay and answer any questions you have. So as mentioned, I am in neurosurgery. We work very closely, basically hand in hand with neurology. But I did go through medical school and training for a surgical specialty to treat neurologic disorders. So that began with medical school in Augusta, Georgia, and a residency of 7 years. That was done at the University of Michigan in Ann Arbor, and then also did a research fellowship there in biomedical engineering. And following that, a 1-year fellowship, which is pretty standard for neurosurgeons who want to subspecialize in a particular area. And my area of interest, of course, is in what's called neuromodulation, deep brain stimulation for movement disorders and epilepsy. That was at Emory in Atlanta. And then in 2018, I started as faculty in the Department of Neurosurgery at UAB in Birmingham. And my position here is 50% clinical and 50% research. And one of the few of the other roles that I have. So I currently serve as president of the Neurosurgical Society of Alabama and director of a center here for neuroengineering and brain-computer interfaces. We're very tech heavy, looking towards future therapies. Also, am associate director of our training program here at UAB for the next generation of neurosurgeons and movement disorder specialists. There are a couple of societies that I work with, and then I have, as mentioned, three boys. So this is my 4-month-old, and we also have a 9 and a 4-year-old. So we stay busy. So one of the common questions that I get is, why did you go into neurosurgery? And when I was going through medical school, I was very interested in the brain and neuroscience. I felt that neurosurgery offers different ways of treating patients than you see in neurology. Was very drawn to the surgical aspects of it. And really, the answer is best summarized in this slide here, where it shows the prevalence of neurological disorders and mental disorders, which a lot of people and institutes will make separate, but we actually think of them along the same vein. And so we have a big problem to tackle. And as far as helping the most people, this is definitely an area where we can do a lot of good. So brain health is really thought of, at least for me, as network health. And that may sound odd, but what that means is that there are diseases that you may be able to see on an MRI scan, like a tumor or a stroke. But there are a lot of diseases that currently don't have great treatments that you can't see on an MRI. And these are thought of as network disorders. This is a picture of Spaghetti Junction in Atlanta. I'm sure a lot of you may be familiar with that area. But that's kind of what happens in the brain, where we have, the brain is an electrical tissue, actually, and signals go back and forth, just like the cars on the interstates there. And so what we are trying to do is to treat these disorders that you can't really see. It's hard to pin down what their pathology, what their problem is, and treat them as network disorders. And so that's why we call it functional neurosurgery. We're trying to restore lost function or abnormal function in these brain networks. And the way we do that is with something called neuromodulation, which basically just means a way to interact with those networks. Deep brain stimulation is one way to do that. And there are several types of diseases that we treat with DBS or deep brain stimulation. Parkinson's disease falls here under movement disorders, but you can see the others that are listed there. For me personally, Parkinson's disease makes up about 60% of my practice. So it is the most prevalent of all the ones listed here and the thing that we see every day. And at UAB, we have a deep brain stimulation program. This is the Department of Neurosurgery. We have two people shown above who we just hired. So one of them started this year and one starts next year. And as I said before, we work hand in hand with the Department of Neurology, which has their own movement disorder division. And so together we treat patients with DBS and with other therapies. We have a program here called the MOVE program, Multidisciplinary Overnight Evaluation Program. And this was started several years ago with the intention of getting patients to surgery faster by allowing them to do everything needed for the workup in basically a 2-day period, so an overnight stay. We also set up a fund at UAB to help offset costs of travel and hotel accommodation so that patients who are coming from long distances or may not have sufficient funds be a part of this program. And we want to be able to deliver the therapy to as many patients as possible. So then getting down a little bit more into the specifics of Parkinson's disease and DBS for Parkinson's, this is a patient diary. It's one of my favorite slides because it's just so well done. I think it comes originally from Dr. Standard. But this is showing something that probably all of you are familiar with. It looks like a roller coaster because that's what you are doing all day. You're on a roller coaster ride with your medications and symptoms. And it's basically an all-day, everyday affair where you have periods of good on time and then periods of off time. And towards improvement of this. Medications have been around for a long time for Parkinson's now. But the goal of DBS is to basically flatten out this line. So instead of seeing the valleys and the peaks there, you basically get a more steady state. And studies have shown it's estimated to be about 6 additional hours per day of good on time, meaning on without dyskinesias. And so there's a very interesting history of DBS that I won't go into. Uh, but basically, when this therapy came about, it was found to be extremely effective in helping to get patients to where their best medication symptoms would be. So for me, it's an incredible therapy. I won't say immediate. That may be a little too optimistic, but we do see results right in the operating room as soon as we turn it on. And as soon as we turn it off, if that is done for clinical purposes, we see symptoms come back. So this is something that interacts with those networks really at a minute-to-minute basis. So this is a picture of what it looks like. Basically involves implanting what we call an electrode or a lead or a wire. We call it all of those things. It's implanted into a deep structure in the brain. Hopefully you can see my mouse, but it's the blue circles here. One of those 3 targets. And for Parkinson's disease, we know that when we implant this device in 2 areas specifically, it will suppress certain symptoms, not all symptoms. It's important to know that it's not a cure. It's not something that will magically get rid of everything, but it is very good at motor symptoms, specifically tremor, the rigidity or stiffness, and slowness that come along with Parkinson's. Those are 3 big ones that most of our patients have. If you don't have those symptoms and you have more trouble with balance, falls, gait disorder, it's not as effective for those unless your medications help. And so once this electrode is implanted in the brain, it's then connected to a wire that runs underneath the skin over the collarbone and is connected to a battery in the chest, very much like a pacemaker for heart disease. And that battery will power the system for several years. There are other rechargeable options, again, very tech heavy.
Dr.
And
Bentley,
yes,
we had a question, if you don't
sure.
mind. They wanted to know, at what point is a candidate in need of DBS? If your symptoms are not bad, are you a candidate?
It's a great question. So typically, patients will have a neurologist who is treating them with medications. And so we see patients in the neurosurgery clinic for consideration of this once medications have stopped being effective. So if the medications are no longer working very well, or you've reached high doses, you're taking it many times per day, or have side effects from the medications themselves, those are the patients that we see. It's a great question. All right. And the results are very immediate. So this is an example of a patient with terrible tremor with the DBS off, and this is from the operating room. I'll get into more specifics of that in a moment, but basically unable to draw a spiral with the DBS off before anything is implanted. And then as we turn up the power of the device, you can see the tremor getting better and better. And we typically do the surgery with patients awake so that they can participate and show us how they're responding to the stimulation, making sure we're not causing side effects. We do give some sedation at the beginning and end to try to relax patients. Most of the time, patients will say that it's not a fun thing that they would want to go through every day. But at the end of it and the next morning, they're glad they did it because they can see the benefit. And the surgery is very well tolerated. And we have an excellent team in the operating room to guide patients along that process.
Would you say it's painful?
The most painful part currently is injecting the anesthetic into the scalp. So we numb up the area, just like at the dentist. If you've had a dental procedure done, you get numbing medication for that. And then you can't really feel anything except pressure. You can hear noises. That's similar to the surgery. The part that causes the most anxiety, and understandably so, is drilling. So when I see patients in the clinic, I again tell them it's not something you want to do every day, but it's also not painful. It is pretty quick. I mean, that lasts about a minute. And most patients tolerate it just fine. If you do have a lot of anxiety about the surgery or specific parts of the surgery, there is an option in a lot of cases to do it under general anesthesia. That would not be our default because we do like to look for side effects, but we would never want to prohibit anyone from getting the surgery that needs it. And so it can be done under general anesthesia. And actually, the results are very similar. Some studies show that there's really no significant difference. So just something to talk with your neurologist about or your neurosurgeon if you are feeling like that's keeping you from doing it, if you're a good candidate for it. Because there's a lot of stuff we can do in the OR to help make you comfortable, to make sure everything is safe as possible, and to get people through it who need it. And this is a video of a patient who may look familiar to you. He has severe tremor, what we call bradykinesia. So he has difficulty with getting up to stand, with starting walking, some slowness. This is after DBS. So much faster movements, very fluid. You can see his personality coming out, much easier mobility, normal appearing. And that's what we see. We do a lot of these surgeries at UAB, somewhere between 100, 130 per year. And that number is growing as we've added new surgeons. And so we know what to expect with outcomes, and this is a very typical outcome for patients. So Parkinson's disease is where DBS started. Again, it's interacting with those networks in the brain. Here, it's specific to motor networks, or how we move, by introducing this electrical current to very specific targeted areas in a very controlled way to restore function. But something that we hear a lot about in our clinics is that the DBS works great. They have great control of those motor symptoms that we talked about. But I wish there was something I could do about my memory, or patients have other what we call non-motor symptoms. And these are things that currently have very few treatment options. So this is where my research comes in. So we are trying to find better therapies for the non-motor symptoms of Parkinson's disease to go along with treatment of the motor symptoms. And hopefully we'll be able to find similar sorts of networks that we can apply DBS to, or potentially other therapies to treat these as well. This is the Center for Neuroengineering that I'm currently director of and work with 4 wonderful associate directors, and this is where the research happens. So it's very collaborative. It involves all of UAB, not just the medical side, but also the campus side, where we have engineers and lots of extremely smart people trying to tackle this disease. And that's the end of my slides. So I'll answer any questions that you have.
And I think everyone is on mute. So if you have a question that you want to ask, you would need to unmute yourselves.
Oh, yep, I see.
Yep. See if we can get Steve's question.
This is Steve. Can you hear me?
Yes,
Yeah.
we can.
I've got a pacemaker for bradycardia. I'm age 75. Would that impact my ability to also receive DBS?
Not at all. We have a lot of patients who have pacemakers, and the only difference is that if your pacemaker battery is on the left side, we would put a DBS battery on the right side. So you would have 2 batteries for 2 different things, but that's the only difference as far as outcomes or ease of surgery, safety of surgery. It's all the same.
My can do I still have the floor?
Yes, sir.
My symptoms are concentrated on my right side, mainly my right arm, and I'm experiencing more tremors in my right leg.
Mm-hmm.
Does DBS treat just one side of your body, or does it treat the whole thing?
Another great question. So in the brain, the wires are crossed. So the left side of the brain controls the right side of the body as far as movement, and the right side of the brain controls the left side of the body. So when we do DBS, most of the time we do it one side at a time. And the reason for that is it's easier for programming. So when you go to get your device actually turned on and programmed for you, we feel like we get a better result when we know exactly what we're dealing with, which side of the body, which symptoms we're dealing with. It also makes the surgery a bit better tolerated. So to answer your question, yes, you would only need one side implanted if your symptoms are all on one side. About 75% of our patients will eventually go on to get both sides treated, but that leaves a quarter of our patients who never do. And so we start with the one side, and then some of them won't ever need it, and the majority of them will come back eventually.
Thank you, Dr. Bentley.
Thank you.
Okay, we had some questions in the chat. How long is the actual procedure?
So for our typical case, it's about 3 to 4 hours. So it's all of a morning or all of an afternoon. It's a long day. If you think about a long car ride where you're uncomfortable, you're not in your lazy boy. That's what what we typically tell patients to expect. But once it's over, it's over. And the most common thing we hear about afterwards is some headaches.
Okay, thank you. And another question, can DBS be used to treat mood disorders such as depression in patients with PD?
It's a great question and is a research interest. So currently DBS, where we implant it, is not involved in mood networks. So we don't really see it have an effect directly on mood. Although if we help with motor symptoms, some patients just feel better. Their mood is better. But that is something that a lot of patients struggle with. And we know that depression, anxiety, some other issues along those lines, they're very common in Parkinson's patients. And that gets back to those non-motor symptoms that we're trying to target. I think we're learning a lot about these networks, and DBS for depression specifically is potentially on the horizon. So that's an area of active research, and I hope within the next several years we'll have update on that.
Okay, what do you typically see as the biggest barrier outside of fear?
Biggest barrier for surgery outside of fear. And again, I hope that if you do feel like that is the barrier that you'll talk with your neurosurgeon and neurologist. But otherwise, I would say, patients that have a lot of medical problems, if we have people who are just in poor health in general, we do see patients who have other medical issues, heart disease, lung disease, kidneys. We treat a lot of very complex patients at UAB and very safe in doing that. But aside from that, those are probably the biggest reasons people wouldn't be a candidate.
Okay, how is the decision made to pursue DBS as a treatment option?
Yeah, so if patients have a neurologist that they're seeing regularly and they're starting to see their medications just not working as well, they're getting a lot of side effects from medications or having to go up on dosages a lot, then that's the time to have the conversation about, is surgery an option? And some patients, even before that time, would ask about it, is it an option? There are some neurologists who are not as familiar with DBS as a treatment. So it is important to ask these questions of someone who has familiarity with the device and how well it works. But at that point, hopefully the neurologist would get in touch with a center that does this a lot. It's important to be somewhere that does a lot of these surgeries and has good outcomes. So ask that question. But that's when you would see a neurosurgeon who specializes in this. And, of course, always happy to field patients directly if you don't have a neurologist that's familiar.
Okay, thank you. Another one, I have heard each person has a different Parkinson's. Can you estimate how long before symptoms get worse?
So that is true. Everybody is a little bit different. There are a lot of themes in Parkinson's, though, where we know a lot of patients will have trouble with tremor, stiffness, slowness, cramping, or something we call dystonia. These are all very common and things we see a lot of, but how much of each of those can vary a lot. Some patients have no tremor. Some patients have no stiffness. As far as how long it takes to develop those things, it is a wide range. We have some patients who go essentially decades without any progression. And we have some patients, even very young, who have a more aggressive form of the disease. We don't understand why that is. It's another area we need to learn more about. So yeah, it can be a wide range there.
Okay. Can the procedure be reversed?
So in the event that you needed the device removed, it can be removed. We have not needed to do that, or patients have not wanted to do that, unless there's some issue with the device itself. There are some cases of the devices, they can have an infection if, just like with any implant or any surgery, really, infection is a risk. It's a low risk. We don't see that too often. But as far as reversal, to the extent that you no longer have this area in the brain implanted, it always would leave a little bit of a lesion there. Typically, if we remove the device, symptoms come back. So more often we're getting patients saying, when can I get it back?
Okay. Can the procedure be done for a weakened voice? Or what can be done, I'm sorry, for a weakened voice?
Yeah, so we call this hypophonia. It means a very soft voice, or a voice that gets softer as you continue to speak. So DBS is not specifically for hypophonia or a weakened voice, but it can be one of the perks of it. So we see a good number of patients who are getting DBS for their motor symptoms, and sort of icing on the cake, their voice strength improves. But if you're not getting DBS, I would say absolutely see a speech therapist. We have many of those here at UAB who specialize in Parkinson's disease. We work very closely with them as well. And they have a lot of techniques that can be used, some treatment options potentially for voice specifically.
Okay. This gentleman says, I had DBS in 2019 for my right side. My tremors have been controlled fairly well, but I had hoped for more relief from stiffness. Is there more that could be done for that? And then he also is saying, by the way, I had a pacemaker implanted in 2020 due to bradycardia. There have been no problems. I am about to have my DBS battery replaced for the second time.
Yeah, so I would say for the first question, the answer would be potentially. These devices have a lot of room to sort of play with the settings. This is done by the neurologist typically. And so if you're having some symptoms that are not as well controlled, there may be room to improve that. If there's not, there are other things that can potentially be done. So I would say the best advice would be to get with your neurologist who's familiar with programming, or see us at UAB. And we can go through a lot of different settings and potential options for that.
Okay. What are the advantages of DBS compared to ablation treatment options?
Yeah, so before DBS existed, the treatment was ablation. So this is back before this technology was developed. We used to put a probe down into the brain and create what we call a lesion. It's really a little controlled burn there. We actually can do this now without putting anything in the brain, using something called focused ultrasound. So in that case, there's no device implanted, there's no incision. But it's basically the same sort of lesioning that we were doing before DBS. And the reason that we moved towards DBS in the first place was because it's flexible. We have the ability to steer the electrical current that's generated in a specific direction. We can turn it up if needed as symptoms progress. We can turn it off if we need to for any reason. And all of that flexibility basically it's not available with an ablation. in that case, what you get is what you get. And so there are reasons that we might do ablation or recommend it for some patients, and especially for those patients who do have a lot of other health problems that I mentioned before, they might be a candidate for an ablation. So it is a very good treatment for patients. And again, we wouldn't want to prohibit anyone from getting it that's a candidate. But at least in our hands, we feel like the flexibility of DBS gives more options.
Okay, and how do patients often describe their experience of living with DBS after the procedure?
So I think that, and I hope that most patients would say normal, just they forget about it completely. That would be my hope. And we do see patients back after several months, and even some years later when they come back for battery replacements. I think that's the case. They have basically just forgotten it's there. They go about their life and do the things they want to do and see us when it's time for a battery change. The Parkinson's disease, it does eventually, in most cases, it is a progressive disease, and DBS is not a cure. So I can't say that at some point they might have more symptoms, that the DBS is not as effective at treating, but usually it's many, many years.
Is the new Medtronic system being used now?
Yes. So
Be a question for Mike next week.
yes, next week is the Medtronic expert coming, so he can answer all of those questions. But yes, Medtronic is a system that we use. There are a couple of recent changes to that system, new technology that's out. And we use at UAB, we try to use all of the most current, latest, highest quality technology that's out there.
Are there more remedies around the corner?
So we are constantly looking for better treatments. So far, there have been several new treatments on the medical side. So there's a levodopa pump that's available. Those are prescribed by the neurologist. I don't have really a whole lot to do with those pumps. As far as in DBS, the technology is constantly improving. And so there may be better ways to measure and treat symptoms of Parkinson's in the near future. There are studies out there of other treatments called gene therapy or cell therapy for Parkinson's, and that is really aimed at trying to change the cells of the brain themselves. Instead of basically inserting electrical current, you're trying to change the cells. Those are very, very early. Can't really say, as far as outcomes, what to expect yet, but they're being done. And we do some of them at UAB.
What do you think is unique about UAB's DBS program?
So the uniqueness of UAB, I would say a couple of things. One is how closely we collaborate. We meet every week in a formal meeting with the neurologists, the speech therapists, the neuropsychologists who are involved in our program, and really just know each other extremely well. We know each other's practices extremely well. And it creates a very streamlined service to our patients. The other thing that I would say is maybe not unique, because there are other places in the country doing this, but I would say it's pretty rare. And that is how much we have available for patients as far as treatment options. And just speaking about DBS specifically, we have many ways that we can do the surgery that is patient specific. So if each patient is different, but depending on what you need, we can do it. And that includes how we do the surgery, the technology used to do the surgery, and then beyond that, just other treatment options in general. So we really do have it all here at UAB.
What would you recommend for someone whose voice has grown considerably worse after their second DBS surgery?
So voice changes is something that we can see sometimes. And I would say usually it means that you need to have the programming tweaked a little bit with the neurologist. I think most of the time we can improve that by just changing the programming. So I would say talk to your neurologist for sure about getting that done.
Is the decision made to have the surgery by the patient or the doctor or both? And how long is the wait to have it once the decision is made?
So the decision is ultimately up to the patient. Our job as the surgeons is to give you the information that you need to make that decision. And a lot of patients will ask, what is our opinion? What would you do? And of course, we can have that conversation. We're happy to help navigate the process and kind of guide you through making that decision. And I think for most patients who are good candidates for the surgery, once they become a little more familiar with what's involved, they do make the decision to move forward with it. But it's something that you have to be comfortable with yourself. So we provide you with the tools you need, and then you decide. And as far as how long the wait is, we are always trying to get this down to as short of a wait as possible. But usually the process takes several months. When the neurologist sends over good candidates to see us in neurosurgery, typically the wait time there is somewhere between 3 and 6 months. We're working on getting that even faster.
Do we have any more questions? Y'all have had some great ones so far.
Yeah, these are great questions.
Okay, is there any evidence of DBS slowing the progression of PD?
Another good question. The answer is no. So DBS is not thought to interfere with the primary underlying process that causes Parkinson's disease. And so it is helping control symptoms. There are other things like the gene therapy that I mentioned, which are intended to slow the disease progression. Having said that, we do hear feedback from patients that they feel like the disease has slowed, whether that's a patient perception or really true. It's hard to kind of tease out. But if you were to read the studies or talk to other people who do this, they would say it doesn't affect progression.
Is this typically covered by Medicare or private insurance?
Yes, both. So for patients who meet those criteria, it's covered by insurance.
That's all the questions we're having right now. I think we still have a few more minutes if anybody has anything else. Let's see. How's your bedside manner?
Bedside manner. So all of us here, both neurology and neurosurgery, I think we have excellent clinicians. I think we take very good care of patients. And so I would say our bedside manner is top of the top of the line.
Are you able to control the device yourself, such as turn it on or off, or adjust the settings yourself?
Meaning patients themselves?
Yes.
You can. So within a certain range. And I tell people it doesn't have a mute button, so you can't give the remote to your spouse and have them do that. But it is set with a range of stimulation. It's a pretty narrow range usually, but you can turn it up or down if you need to. And you can turn it on and off. You have that capability. Some patients basically throw the remote in the trash. They don't want to mess with it. That's totally fine. Other patients like to have that option. So it's just up to you.
And then once the device is implanted, are you able, or can you like hurt the device? Like, could you potentially break the wire or?
It's extremely rare. And I don't think I've actually seen a case of that where the patient has done something to damage it. Even in things, like car accident or some injury, hopefully that wouldn't happen. But even in those situations, we don't see that it's damaged.
This isn't really a question, but this is some praise that someone wrote based on your attention detail of each question. I would say you have a great bedside manner. Thanks for helping with the understanding of DBS.
Oh, you're welcome. And happy to, if there are other questions afterwards, I can share my contact information with Ellen, and I'm happy to answer any other questions.
Thank you. Well, if anybody has any more questions, we can maybe take one or two more. I know Dr. Bentley has a busy day and things and patients to see. So we'll give it a few more minutes if anybody has anything left they would like to ask. And okay, well, Dr. Bentley, we want to thank you so much for your time and your consideration and all the preparation you did to help us with this. You truly did an amazing job, and we appreciate it very, very much. And like I said in the beginning of the webinar, we will have a follow-up email sent with a link to this presentation, so you are able to review it and look back through Dr. Bentley's answers in her slideshow. And then to remind you all that this DBS series is this is part one. And next week we will have Mike Tapley, and he is with Medtronic. So,
That's the link to next week's webinar.
okay, thank you. Oh, wait, something just popped up in the chat. So
Yep.
the link to next week's webinar is right there, so you can go ahead and register for that one. And it will, like I said, will be with Mike Tapley, a Medtronic's rep, and he will kind of go over the device and how it works and all things DBS. And that will be part two, and then part three will be the following Thursday, where we will speak with a DBS participant to talk about their journey. So, if there are no more questions, then we can wrap up. And we thank you, Dr. Bentley, so very much for your time. We appreciate it. And we thank you all for coming and joining us today.
Thank you. It was great to be here and to talk with everyone.
Thank you so much for taking the time. And we